So okay.
تمام.
Just let me double check. I don't know if we took this one or not. I'm not sure.
Yeah,
maybe
we took
this one. Okay.
Yeah, the right pubic lemma.
Okay, then we left. Yeah, case number 7. Yes.
Lymphoma, I think it was.
Yeah, it was lymphoma. Yes. Okay, so 5 minutes starting now.
Okay, doctor. 5 years. 1 month history. Left thigh swelling. Not wait. تمام دكتور. Next.
أحمد.
نعم دكتور. دقيقة.
You have to describe.
نعم. دكتور in the left hip يعني joint show irregularity and irregular and foci of sclerosis of femoral يعني femoral head abnormal position compared to the other side and also on the right knee a thick band of metaphyseal band, thick metaphyseal band. Picture suggest يعني metabolic disease دكتور يعني.
Okay, so what do we suggest?
يعني دكتور نحتاج نسوي مثلا لاب انفستيجيشن اذا اكو اور ام ار. تمام. abnormal signal intensity involve the left hip and foci of abnormal signal intensity in the femoral head and the femoral bone with edema. With the edema involve soft tissue and also abnormal signal intensity in the bone marrow.
So we have 1 minute left.
Yeah. فيعني دكتور احنا هسه بهاي الحالة يعني نفكر احنا هسه also يعني نفكر في metabolic disease يعني. يعني ممكن نعطي differential diagnosis، ممكن يعني vitamin C deficiency.
Okay, we have 15 seconds left.
Or infection.
Okay. You want to make any recommendations?
يعني الدكتور نحتاج يعني هو يعني إذا فيتامين سي ديفيشنسي نحتاج إنه ندزه يعني المريض for clinical and lab correlation.
Okay, so your time is up. We finished the 5 minutes. Okay, so let's go over this. Yeah, unfortunately, I disagree with you. The radiographs showed very clear periostea reaction, and you could also see maybe something like Codman's triangle here. Here, you may actually describe it as onion peel periostea reaction, and it's a diaphyseal lesion. So do you know what onion peel periostea reaction in pediatric population means?
يعني عندنا يعني periostea reaction يعني عندنا يعني فد مع abnormal Ewing sarcoma دكتور.
Yeah, normally it's Ewing sarcoma. So remember this terminology really well, because this is a very sinister appearance on the radiograph. This indicates a very aggressive process going on in the femur. So onion peel periostea reaction is very worrisome for Ewing sarcoma, and in this pediatric population. And you commented on the femoral neck. Femoral neck is destroyed. So this bony destruction is an aggressive process here, and also we see periostea reaction here. We see Codman's triangle here. So it's an aggressive process. And on the MRI scan, actually T1 is the best sequence for bone tumors. So if you compare the right femur to the left femur, you see on the right side there is marrow fat, but the marrow fat is completely infiltrated on the T1 on the left side. Also, there is extraosseous mass here around the left femur. So it's a quite extensive bony infiltration process with extraosseous mass, onion peel periostea reaction. Overall appearances are in keeping with Ewing sarcoma. I don't think there is a differential diagnosis for this one. You could just go for Ewing sarcoma, recommend pediatric orthopedic referral, and CT-guided biopsy or open biopsy with coordination with a sarcoma surgeon. You could also recommend doing bone scan, doing CT scan of the chest, looking for chest metastases, and bone scan for other skeletal metastases. This one here could be another bony deposit here, could be metastatic lesion on T1. So it's I think in the bone tumor talk, we said if there is an aggressive primary bone tumor, we would recommend bone scan and CT scan of the chest. Okay, so we're done with this case. Let's move on. Do we have another resident?
دكتورة فاتن.
نعم أستاذ صباح الخير.
تفضل يا صاحبي.
إن شاء الله.
Okay, so we're going to start now. 5 minutes starting now.
إن شاء الله.
Ready for the images?
Yes, okay, ready. Right medial thigh pain.
Correct, yeah.
يعني multi-sectional MRI images show high signal intensity in the medial muscle compartment, mostly involving the adductor magnus muscle, يعني medial muscle compartment, we can say. طبعا بالنسبة للفات separation images بالفيرست image other T1 image there is no obvious obvious change in signal intensity. The coronal images also there is a high signal intensity on the medial muscle compartment. Yes. Nearly surrounding the femoral vessel. Only these sections, Ustad?
Yeah, only these images.
يعني يعني obvious إنه كأنه أكفد يعني I cannot see any tear of the muscle or any defect, but there is an abnormal signal intensity in the muscle, focal medial muscle, surrounding the like a nerve structure in the center of the muscle, and nearly abutting the vascular يعني femoral vessel. Just that. No bony lesion, no others, no mass lesion. It can be denervation injury or even يعني also there is some focal atrophy of the muscle, history of gaming, I think.
Yeah,
it can
soccer,
yes,
football,
yes,
football,
soccer, yes. It can be in some sort of injury. It may be يعني muscle injury يعني no definite tear يعني just in focal increased signal intensity. يعني I can't see the exact location. It may be myotendinous junction بالcoronal images, maybe focal tear in muscle. No obvious gap, no obvious retraction. Just that. يعني بس هذا اللي قدرت أشوفه أستاذ إنه ال abnormal signal intensity near myotendinous junction تقريبا.
Okay, are you finished?
هو X-ray no X-ray أستاذ؟
No X-rays.
No. تمام. هذا الأستاذ اللي قدرت أوصل لهم صراحة. يعني no other findings.
Okay, yeah, I think we have 1 minute left, so yeah. Okay, let's go over the case. I think you did really well. The history was very useful. This is a young soccer player who developed sudden medial-sided thigh pain during soccer game. So I think what we need to do here, really, we need to go over the anatomy. So you said medial compartment. What's the name of this medial compartment? So let's go over the compartments. Which compartment is this one?
This is quadriceps muscle group. Adductor.
This is okay. This is quadriceps.
Adductor muscle group. Quadriceps, yes. Quadriceps femoris.
So this is a quadriceps compartment. This one?
This is the posterior muscle group. The hamstring muscle.
Hamstring compartment, and this compartment?
And this is the lateral muscle group, lateral compartment.
No, there's no lateral. There's quadriceps, there's hamstring, and there is this one. We said medial sided.
Yes.
So this compartment. What's the name of this compartment?
This is the adductor muscle group.
Yes. Okay. So it's the adductor. Okay.
Adductor.
So
yes,
we just need
quadriceps, hamstring, and the adductor muscle group.
Okay. Yes. So we just need to get the terminology right. Okay. So remember in the soft tissue tumor, we talked about the compartmental terminology. Yes. So on the thigh, you have the quadriceps, you have hamstring, and you have the adductor compartment. This muscle here doesn't really belong to the adductor. Yes.
Sartorius muscle.
Yeah. Well, sartorius is here actually. This is a gracilis. Sartorius covers covers the vessels. Okay. No. So this is the reason why I actually included this case in the in the mock practice. So then, because I noticed that most of the residents have, they need some knowledge about compartmental anatomy. And I put this case in the mock practice just to make sure that you guys know the compartmental anatomy very well. And this is very important not only for muscle injury and musculoskeletal trauma, but also for soft tissue tumors. So we got all the anatomy now cleared. Now move on to the pathology. So which muscle is this one? He said, I think he said adductor magnus.
Yes, looks medial, يعني medial muscle group.
Okay, so if this one is adductor magnus, then what is the name of this muscle?
هذا راح يكون الهامسترنج، احنا قلنا انه posterior.
This is the hamstring here.
Yes.
This is hamstring. Okay, so this is the intermuscular fat plane. So
Yes.
we have two muscles here in the adductor compartment. What's the name of this one and this one?
ها أستاذ عفوا السيممبرينوسس والسيمتندينوسس يعني راح يكون عندنا هنا.
Okay, so semimembranosus, semitendinosus are in the
Yes.
hamstring compartment.
No, no.
So in the hamstring compartment, you have the biceps femoris, you have semimembranosus, and you have semitendinosus. So in the adductor compartment, we have adductor longus and adductor magnus. And you also have adductor brevis, but adductor brevis is actually here. So by
More anterior.
the slice, this slice actually is at this level here. So by now, adductor brevis is not visible.
Yes.
It's not visualized, yeah, because we are very distal. We are kind of mid-thigh level.
Yes.
We are at the level of the here, at the edema here. So
Yes.
what we have left in the adductor compartment is adductor longus and adductor magnus.
Adductor magnus. Yes.
Okay, so this one is actually muscle injury tear, complete tear of the adductor longus here. Okay,
Yes.
and how do we know it's a complete tear? This is what we describe as bunching up. So if you hear about bunching up, is when the muscle is torn and retracted, and it looks like a rounded mass.
Yes.
Okay, so this rounding of the muscle stump is what we call bunching up. So bunching up, and sometimes it actually can mimic soft tissue tumor. That's why we have skin marker here, because it's actually presented as a mass. And sometimes this bunching up can lead to false diagnosis of soft tissue sarcoma. And this is the reason why we did this MRI scan on this patient, because the muscle was completely torn, retracted, and was mass-like appearance to it. So on MRI scan, what we see is we see this bunching up, and we know that it is a complete tear of the adductor longus muscle with some edema at the myotendinous junction. I think you call this is a nerve. Actually, this is the retracted tendon.
Retracted tendon, yes.
Yeah, retracted tendon surrounded by edema.
Yes.
And so this is complete tear of adductor longus. Okay, let's move on. Do we have another resident?
دكتورة هنيدة.
نعم صاحب أستاذ.
تفضلي صباح.
Okay.
Yes.
Right. 5 minutes starting now.
Okay. So you have 33 years old male with the left shoulder pain and weakness. Okay, for 6 months. So we are presented with the ultrasound scan of the shoulder. I think we have a large cystic structure following the spinoglenoid notch. Maybe presenting a paralabral cyst. Yes.
Yeah, sorry, do you want to make a recommendation?
Yes, I think we need to do full scan if we have another ultrasound images or MRI images. Okay. Okay, so we have a large cystic fluid signal intensity structures that fill the spinoglenoid notch. I can't see any defect or any relation to the adjacent labrum. Maybe a ganglion cyst. There is a high signal intensity involving the supraspinatus tendon and muscle, maybe because of the nerve compression on the supraspinatus nerve at the site of the spinoglenoid notch. Yes, I think this is a large cystic structure causing compression on the supraspinatus nerve at the site of the spinoglenoid notch and causing a high signal intensity in the innervating muscle. Sorry, infraspinatus muscle. Yes, infraspinatus muscle denervation.
Okay, we have less than 1 minute left.
Actually, I think that that is my answer.
Okay, you finished here?
Yes.
Okay. Yeah, I think you did well. The ultrasound scan was really helpful. You have cystic lesion in the spinal glenoid notch. You commented on it. Maybe you can just also say it measures 4 centimeters by 1.6 centimeters. But use all the information available to you on the image. All the information available to you is helpful. But you commented on it really well. And on MRI scan, yes, there is paralabral cyst. And I think you can see the epicenter here. That's the epicenter of the cyst, is from the posterior labrum. So it's a paralabral cyst with impingement on the nerve. You said supraspinatus nerve. Do you want to think about it again? What's the name of the nerve?
Sorry, yes. It is spinal glenoid sub. Sorry, I forgot the name of the nerve, but it is the compression on the nerve in the spinal glenoid node that causes the innervation in the infraspinatus muscle.
Okay, so we need to get our anatomy right. The name of the nerve is suprascapular nerve.
Suprascapular, yes.
Okay, so suprascapular nerve can be entrapped in 2 areas. The first area of entrapment in the suprascapular region, which is around here. And the second area of entrapment is in the spinal glenoid notch. Do you know what the difference is if there is entrapment in the suprascapular notch versus entrapment in the spinal glenoid notch?
Yes, if there's compression of the suprascapular nerve on the suprascapular notch, so there will be denervation of both muscles, so the supra and the infraspinatus muscles, but only compression in the side of the spinal glenoid notch. So this is after the giving of the branch to the supraspinatus nerve. So there will be only denervation of the infraspinatus muscle.
Yes, exactly. So this is what we're seeing here. We see fatty atrophy. You see these streaks of fat in the infraspinatus muscle, but supraspinatus muscle is fine. There is no fat in it. And also, that's why you have the sagittal T1. You see that the supraspinatus muscle has no fat, but infraspinatus muscle has fat in it. And this is the cyst here. And there's some edema as well in the muscle. So the muscle is edematous. You can see the edema here compared with the deltoid muscle. Okay, so all in all, this is a paralabral cyst compressing the suprascapular nerve in the spinal glenoid notch associated with denervation myositis of the infraspinatus muscle. Okay, fantastic. You could also make a recommendation to do MRI arthrography
Yes.
because it is the gold standard for labral tears.
Yes.
Okay, all right. Now, do you have another resident?
دكتور عبد الله جمال.
نعم أستاذ صباح الخير.
تفضل صباح.
Okay, 5 minutes starting now.
Okay,
Ready?
right, yes. There is an AP and the lateral view of the knee joint. I think there is some what's called a piece of bone likely avulsed from the lateral femoral condyle.
Lateral femoral condyle here, you mean?
Yes.
Okay, well, this is the popliteus hiatus. This is normal anatomy.
Yes. Okay.
So if we go back to the history, where
yes,
is the problem?
anterior
Where
knee
is
pain. Yes. Okay.
Okay.
Okay. It's
So that-
anterior. I think there's a avulsion of the inferior pool of the patella. I think there's is there any further imaging like MRI?
If you are recommending MRI, I can show you MRI.
Yes, doc, I see any irregularity in the inferior patellar. Yes, multi-section MRI. There is edematous, edema in the inferior pool of the patella. I not really see well the inferior patellar tendon attachment at the inferior pool of the patella. With the bone marrow edema in the patella. Some distortion in the inferior fat pad and patellar fat pad. I think it goes with the jumper knee. It's in general it's called Sinding Larsen Johansson disease, I think. Yes, doctor, this is my answer.
Okay, you finished?
Yes.
Okay, yeah, perfect. So let's go back to the radiograph. Yeah, always pay attention to the history.
Yes, sorry.
Every information you are given in the history has a meaning. So without even looking at the images, if you have a young basketball player who presented with knee pain, what do you think it might be? Just without looking at the images.
Yeah, it's
Why-
sport injury, avulsion injury.
Okay, why basketball specifically?
It's jump, yes.
Yeah, because they jump
a lot
lot.
of jumping,
Yeah.
yes.
Yeah, okay. And when they present with knee pain, we immediately think about jumper's knee.
Jumpers, yes.
So you could tell that the inferior pole of the patella is irregular.
Yes.
Yeah, maybe you're right. Maybe there's a small bony avulsion here. Okay. Now, there is a difference between Sinding Larsen Johansson and jumper's knee. Do you know what the difference is?
يعني جامبرز ني استاذ يعني abnormal signal تصير يعني باليونج ايج او مو باليونج ايج عفوا السندج لارسن باليونج ايج يعني before fusion يعني immature skeleton.
Yeah. So Sinding Larsen
Yes.
Johansson is actually traction apophysitis.
Yes.
It's a traction apophysitis of the inferior pole of the patella, and it happens in the adolescent age group.
Adolescent, yes. The jumper knee in young age adults.
Yes, jumper's knee is actually the primary pathology is in the tendon.
Yes.
But Sinding Larsen Johansson, the primary pathology is in the patella. Okay. Yeah, and you commented on it. Maybe be more descriptive with the appearances on MRI. So, for example, the way to describe this one, you could say there's thickening and edema of the proximal pole of the patella. There is fluid signal intensity. You may suggest interstitial delaminating tear. I think there may be some fluid in the prepatellar bursa, if you want to comment on that, because sometimes they may have prepatellar bursitis because of the overuse of the extensor mechanism. There's also edema and fat pad impingement of half-as fat pad here, okay, because that's also another appearance. So jumper's knee is actually like it's a constellation of findings: the tendon, the fat pad, the bursa, all of them together. Okay, so that's normally how I would recommend you describe it. Okay.
Thank you, sir.
Problems. Okay, let's just see what messages we have here. Okay. Yeah, okay, perfect. So let's move on to the next case. We have a resident.
دكتورة زينب خضير. دكتورة زينب.
نعم أستاذ، صباح الخير.
تفضلي، صباح الخير.
Okay, 5 minutes starting now.
أوكي، أستاذ جن. X-ray view show soft tissue edema around the tibia, thickening in the cortical, and see small nidus in cortical edge at mid of tibia. Please, change. Yes.
Okay.
The thickening at this side cortical with the so tissue edema. If you any change to MRI, please, if you are present.
What's your imaging of choice? What's your first imaging of choice?
CT. Yes. multiple section, CT scan, axial and sagittal. We see also a soft tissue edema with the abnormal signal intensity, abnormal signal intensity, and diffuse cortical diffuse cortical sclerosis, and abnormal signal intensity lesion in mid of in mid of يعني tibia with the central lucent, يعني mostly with the osteoid osteoma, and يعني point in history إنه in response to the non-steroidal, it's more goes, and child more goes with the osteoid osteoma. يعني shape of يعني والsize less than 2 cm, more good with osteoid osteoma, and يعني sclerosis with nidus. I think يعني osteoid osteoma. No periosteal reaction, no bone destruction, يعني sign of non-aggressive lesion, non-aggressive tumor. With the mild soft tissue, mild bone marrow edema adjacent to correlated to tumor. يعني benign يعني feature of benign tumor. Recommendation يعني ممكن يعني we need يعني more to يعني confirm the diagnosis, we need يعني bone scan. I think يعني finish يعني.
Okay. All right, let's go back to the radiographs. I think you did well on the radiographs. You detected the area of cortical thickening, sclerosis, and the nidus. I think we just need to get the terminology right, because you said there's edema. We don't normally see edema on the radiographs, neither on CT. You could say there is soft tissue swelling, but edema is not really cannot be. If you saw soft tissue swelling, it could be because of edema, could be because of tumor, could be because of inflammation, but we don't really see the edema on the radiographs anyway. Then we move on to the CT, and I think also we need to get the terminology right, because you were saying signal intensity all the time. And signal intensity is MRI terminology, not CT terminology. You said bone marrow edema, and again, that is something we see on MRI, not on CT. On MRI, you could use the word density,
Yeah.
high density, low density, but
Yes.
not intensity.
Yes.
So it's a different
Yes.
terminology. And
Yes.
edema, remember, is not something that we see on CT, especially in the bone. That's for the MRI. You said you would recommend a bone scan to confirm the diagnosis, but actually a bone scan cannot confirm the diagnosis. If you, what's your differential diagnosis here? If you did not have history of night pain responding to NSAIDs,
يعني ممكن infection.
like what?
يعني osteomyelitis.
Yeah, what's the name for that in pediatric population?
يعني Brody's abscess ممكن.
Yeah, Brody's. So Brody's abscess is your main differential diagnosis. Do you think bone scan will help you differentiate Brody's abscess from osteosteoma?
Yes, in bone scan can differentiate it.
How can you differentiate osteosteoma from Brody's abscess?
I think, yeah.
Yeah, so bone scan is not
Okay.
really a reliable test to differentiate between osteoid versus Brody's abscess, because both of them will show increased uptake. Maybe you see the donut sign on Brody's abscess, but really, really very subtle. The best test to differentiate between Brody's abscess and osteoma is actually dynamic MRI, which I don't have here on this patient. But if you want really to differentiate between the two, especially if the history was not consistent with osteoma, you could suggest doing dynamic enhanced MRI. So you see with osteoma, you see sharp peak enhancement and then early washout on the dynamic curve. So that's how you differentiate between the two. Okay, the last thing is that, remember we said when we take the cases for the exam, we will make observation. So observe all the findings, then describe all the findings, come up with a differential diagnosis or narrow it down to one diagnosis and make a recommendation for further management. So that's your system. So in this patient, the last part of it, can you make recommendation for further management?
By laser ablation, I think.
Yeah, well, it could be laser,
Radio
could be,
frequency or laser.
yeah, it could be laser or radio frequency. And both of them actually can be done in the radiology department. So you can say, well, the history is night pain responding to NSAIDs, and the CT shows features in keeping with osteoma. I would recommend referral for RF or laser ablation. So that's your further recommendation for further management. Okay. All right. Do we have, sorry, before we move on.
دكتورة دعاء ويانا.
نعم أستاذ، السلام عليكم.
تفضلي.
Okay. Just checking the responses here. Okay. All right. So I'm going to just get the timer set up here. We have 5 minutes starting now.
نعم دكتور، next.
تفضلي read the history وبعدين سوي description بعض.
Okay, you finished with the history?
Yes, 45 years female with right deltoid soft tissue swelling and shoulder pain, radiated to the arm with no history of trauma.
Okay.
There is hyper-intense mass-like, well-defined, seen within the intramuscular compartment. It have a central target-like lesion, central hypointensity, suggesting well-defined it is, and have no extension to other compartment. Mostly suggesting nerve sheath tumor. نعم دكتور, this is my answer.
Are you finished?
Yes.
Okay, all right, okay, so let's get the system here. So first of all, before we describe the pathology, we need to comment on what the test is. I don't think you said this is an MRI test.
Yes, sorry, it's MRI.
Because
Sure.
if I'm talking to you over the phone without looking at the images, I don't know what test you're looking at. So yeah, always would be great to start with something like multiplanar, multi-sequence MRI scan of the right shoulder, and then move on to your describe the findings. So the findings here, we would say there is an oval-shaped soft tissue lesion within the deltoid muscle. I don't think you specified what muscle it is. I think you said it's a lesion in the intramuscular compartment. So again, we need to really know the muscle anatomy, whether it's a muscle injury or tumor. We have to specify what muscle it is. We cannot just say in the intramuscular compartment, because orthopedic surgeon or the sarcoma surgeon, if they are going to remove it for excisional biopsy or for resection, they need to know which muscle it is, because they may remove the entire muscle with the lesion. So always remember your muscle anatomy. If the lesion is related to the muscle, then you have to specify which muscle we are talking about. So we will say this is an oval-shaped soft tissue lesion situated in the lateral fibers of the deltoid muscle, which demonstrates slightly hyperintense signal intensity to the muscle on T1, and it is hyperintense signal intensity on the T2 fat-saturated sequence with central low signal intensity, giving it the target sign appearance. Do you see another appearance that goes with nerve sheath tumor?
It is a spindle shape.
Yeah, so the target sign, yeah, any other
Split fat
finding?
also.
You see the split fat here?
Here.
Yeah, this is your split fat sign.
Yes.
Okay. So you need to make observation of all the findings. So when you call it nerve sheath tumor, you have to convince me that it is nerve sheath tumor and provide me with all the radiologic feature of soft tissue tumor. So split fat sign, the target sign, and also going back to the history of this patient, pain shooting down the arm. It's more a neurogenic pain. Okay.
Yes.
So, and then the other thing, remember our system, describe the findings, interpret the findings, differential diagnosis, and further management. Okay, so what is the further management for this patient?
يعني search for other sites if it is syndromatic, and if it's caused يعني sign and symptom, surgical removal.
Okay, would you biopsy this one?
No.
Why?
Vascular lesion.
No, they are not vascular normally. So they're not like soft tissue AVM or hemangioma. The answer, yes, you can biopsy this one, but you biopsy it after consultation with sarcoma surgeon. So what is the problem with doing a biopsy on a nerve sheath tumor?
I don't know, sir.
Yeah, the most common problem or the most significant problem doing biopsy, especially image-guided biopsy, is pain. It's a very painful tumor because it's a nerve tumor. So because of that, actually, we don't do the biopsy without GA. So normally these patients have general anesthetic before we do the biopsy because it's really, really painful. So again, having the knowledge about how to manage soft tissue tumors and remember the system, okay, about making further recommendation. All right, I think we're done with this case. Just check the responses here. Split fat sign, painful. Yeah, exactly. Okay, let's move on to the next case. Do we have a resident?
Yeah. دكتور بهجت عبد الرحمن.
نعم أستاذ، صباح الخير.
صباح الخير.
Okay, Behjat, we have 5 minutes starting now.
24-year-old female patient, tense sclera, lateral ankle pain, and snapping. Okay, أستاذ. A multi-section MRI of the ankle joint, axial coronal. There's joint effusion with a fluid collection around the tendon, Achilles tendon, I think.
Sorry?
There is mild moderate joint effusion with a fluid collection around the tendon. Pollice is longer, I think, tendon. Tendinitis يعني. Normal one signal intensity, no obvious bone lesion. I see fluid يعني fusion around the joint. Also يعني fluid collection around the tendon.
Do you know why I moved the image?
عفوا أستاذ شنو؟ What's it?
I've just moved this image a little bit. So, okay. Are you done with the case or are you still?
Finished.
Okay, so we always go back to the history and try and make sense. So you have tennis player with lateral ankle pain and snapping. What do you think the pathology is?
Lateral peroneal tear يعني peroneal tendon, lateral ankle of the.
So if you have peroneal tendon tear, you wouldn't get snapping because the tendon is torn. So why do you get snapping and pain? Okay, so I think you were talking about this tendon.
Peroneal tendon.
No, when you said there's a tendon with a fluid collection, did you?
Pollicis longus.
Okay. So do you want to take another look at these images? And after we talked about lateral ankle pain and snapping, do you want to take another look?
Also around the peroneal tendon, يعني have high singular intensity around the.
You mean here? Yeah.
Yes.
Okay. So where do you normally expect the peroneal tendons to be? Normal anatomic position of the peroneal tendons.
Lateral to the malleolus يعني.
Lateral to the malleolus or posterior to the malleolus?
Posterior lateral.
No, they are normally posterior. They're normally here. So where are these peroneal
So
tendons?
dislocated يعني dislocated.
Yeah, so there is lateral peroneal tendon dislocation. Okay, you can even see it on the coronal. So the tendons actually should be here, but the tendons are here. Okay, so snapping, what is happening with this patient is because they are tennis players, there is a lot of plantar flexion and dorsiflexion of the ankle joint. So when they do plantar flexion and dorsiflexion of the tendons come back here and then they snap. They come back here and then they snap. Okay?
Yes, sleeping of
So
the tendon.
Yeah, so the tendon is actually snapping back and forth between here and here. So that's why she has lateral ankle pain and snapping. Why do you think this patient developed dislocation of the tendon, peroneal tendons?
A rupture of the ligament.
Ligament or retinaculum?
A retinaculum.
Which retinaculum? Peroneal retinaculum. Okay, so they normally, so normally if you want to look at if you look at the normal MRI, you should see the tendons here and you should see retinaculum from here back to here. Okay, so you should see a retinaculum. This retinaculum is actually here and it's torn, is not attached to the fibula. So there is tear of the peroneal retinaculum. That's why the tendon is dislocated. Okay, there is a fluid as well here, maybe some tenosynovitis. One of the risk factors for peroneal nerve dislocation is actually a convex fibula. You see the fibula is convex? Normally the fibula is concave. Okay, so normally the fibula is concave to allow the tendons to rest here. But when the fibula is convex, it's a risk factor for these tendons to dislocate and rupture the peroneal retinaculum. So all in all, the way you describe this one, you would say lateral peroneal tendon dislocation with rupture of the peroneal retinaculum. Appearances are concerning for peroneal tendon dislocation and snapping due to peroneal retinaculum rupture. So yeah, that's how would you be able to confirm the snapping if this patient, let's say we did the MRI scan and the tendons were here, okay, but patient would confirm, would say, I always have snapping in this area. So if you scanned with MRI and you saw the tendons here, how can you confirm peroneal tendon snapping?
The tendon moves with the movement of the joint, return back and will sleep.
Yeah. So on imaging, what imaging test you can use to confirm peroneal tendon snapping? You can use dynamic ultrasound. Okay.
Yes.
So you can do dynamic ultrasound.
Real time.
Yeah, real time. So you can ask the patient. You put your hand on the plantar aspect of the foot, and you ask the patient to push your hand. Okay, and while they are actually doing plantar flexion by pushing your hand, you scan the peroneal tendons, and you ask the patient to dorsiflex and plantar flex, dorsiflex under against resistance, and your hand will be the resistance. So you put your hand on the plantar aspect and you apply resistance to the foot, and you ask the patient to do plantar flexion and dorsiflexion. So that's how you reproduce peroneal tendon dislocation. Okay. All right, let's check the responses. Retromalleolar, ultrasound, yes, correct. Peroneal tendon dislocation, painful, okay. All right, so we're done with this one. Do we have another resident?
دكتور حسين حمود.
نعم أستاذ، السلام عليكم.
عليكم السلام. تفضل.
Okay, so 5 minutes starting now.
Next, please. X-ray of the knee, AB and lateral view. regarding tibia there is يعني في abnormal يعني lucency the lower part of the الباتيلا there is abnormal lucency in the patella the lower aspect of the patella. And there is soft tissue swelling بالupper aspect of the leg. Is there is MRI?
Are you recommending MRI?
If there is MRI for further evaluation. Multi-section, multiplanar MRI. There is a joint fusion. There is abnormal signal intensity in the ACL ligament. And abnormal signal intensity at the Hova fat pad. Increased signal intensity. Also there is abnormal at the يعني suprapatellar area there is يعني في signal void, multiple rounded signal void.
What we call this?
يعني هي fat density يعني هي بالفات separation رايحة يعني ممكن تكون lipoma arborescens. وبالنسبة للهوفا فات باد أنا أشوف يعني there is an increase in signal intensity ممكن هوفا فات باد impingement يعني بس not sure.
Okay, so we have less than 1 minute.
يعني my conclusion إنه there is abnormal high signal intensity بالهوفا فات باد وال ACL يعني thicken and there is high signal and there is بالsuprapatellar area there is يعني signal void and suggest lipoma arborescens or another differential diagnosis pigmented villonodular synovitis.
Okay.
Another finding there is soft tissue swelling anterior and posterior no any compartment.
Okay, so your time is up. All right, let's go back to the history. 61-year-old, progressive knee pain and swelling for 1 year, no improvement with conservative management. On the radiograph, what we see actually is joint fusion here, moderate-sized joint fusion. Joint spaces are otherwise fine, no focal body lesion, no calcification. So remember I said no.
إذا تسمح لي بالنسبة للباتيلا normal يعني.
Patella is normal. Okay, so remember I said
يعني.
Yeah, it's normal. So yeah, if you just remember, I said no calcification. All right, because this is important. On the MRI, what we are seeing is actually, what sequence is this? These two, this one and this one.
Proton density FATSAT.
Well, this one is PDFS. This is SASH-T1. So what is this one and this one? Gradient. Okay, these are two gradient sequence. So why do we have a gradient sequence in this knee MRI? What is the usefulness of gradient echo for the knee or any joint?
gradient يعني ممكن for calcification ممكن
Okay,
or hemorrhage.
Yeah, okay. So what we're seeing in this patient is actually diffuse nodular synovial thickening. Okay, you can see it here. I think you said there's nodular, or you said there is synovial abnormal foci. So these are the foci here, and you can see even here, and you can see here, there, and here, and here. Okay. So there's only one diagnosis for this patient. What is one diagnosis? What do you think the one diagnosis, if you want to choose one diagnosis for this patient?
The one diagnosis is pigmented villonodular synovitis.
Okay, so what do we normally see on the gradient echo in patient with PVNS? What do we call this appearance?
هو susceptibility artifact.
Susceptibility artifact, what is the name of it? It's Bloom artifact, okay?
Bloom artifact, no.
Yeah, so this is the Bloom artifact. This is why we did gradient recall echo sequence on this patient to look for the Bloom artifact. So diffuse nodular, and remember these foci are hypointense on all the sequences, hypointense on PDFS, hypointense on T1, and they bloom on the gradient echo sequence. So this is a PVNS, patient with a PVNS. What is the treatment for patient with PVNS?
يعني هو المفروض surgical يعني synovectomy.
Yeah, total synovectomy. That's why you need to image the entire synovium. So if you had an image, I'm trying to actually move this bar away so we can show you here. Sorry. I think on this image, they imaged the synovium was partially imaged on this one, so we had to recall the patient and include the entire synovium, because when they do total synovectomy, they want to see how extensive the disease is. So make sure with PVNS, you have to scan a large field of view in order to see the entire synovium. You commented on how fast fat pad is actually normal because the fat is intact. Okay, if there was any edema, I would normally see loss of the fat signal intensity on T1, but the fat is preserved. So the Hoffa's fat pad is normal, and you can see the patella is normal. There's not even edema in the patella. Okay, so this is PVNS. Okay, do we have another resident?
دكتورة لنشة.
نعم أستاذ.
Okay, 5 minutes starting now.
Okay. What I can multiple section MRI of the ankle joint, sagittal and axial view. I can see that there is thickening of the Achilles tendon, but intact with no tear. Also, on the with minimal joint effusion, ankle joint effusion. It could be a chronic tendinosis of the Achilles tendon. Also in the there's no bone marrow edema, no bone lesion. Actually, that's my finding, thickening and of the Achilles tendon, just no rupture.
Are you finished with the case or you still looking at it?
Yes, finished.
Okay. Okay. All right. So yeah, history of retrocalcaneal pain. No history of acute injury. Yes, you are absolutely right. There is Achilles tendon thickening. Which plane is the most useful plane for Achilles tendon thickening?
Axial.
Yeah, axial plane is the best sequence for Achilles tendinosis. How many types of Achilles tendinosis do we have?
I don't know.
So there's insertional and non-insertional. Which one is this one?
Non-insertional.
Do you know the difference between insertional and non-insertional tendinosis?
No.
So non-insertional tendinosis like this one, okay, because it's a fusiform. So the way you describe this one, you can say there's a fusiform thickening of the Achilles tendon, non-insertional segment of the Achilles tendon. The non-insertional tendinosis is mechanical or biomechanical because of the overuse of the Achilles tendon. Whether a patient is playing tennis or basketball, the overuse, or even a runner, you can develop non-insertional tendinosis of the Achilles tendon like this one. Insertional tendinosis happens here, okay, and most of the times insertional tendinosis, we see it in patients with seronegative arthropathy like psoriasis. So that's why it's important we distinguish between insertional versus non-insertional tendinosis, because the pathology is very different, the treatment is very different, the prognosis is very different. There's one more finding as well in this patient,
Yes,
which also...
there is edema in the fat pad in the posterior compartment of the ankle joint. I think Kager fat pad.
Well, Kager's fat pad is this one. Which part, which anatomic structure is this one? Retrocalcaneal bursa.
Yes.
Okay, so there's retrocalcaneal bursitis, and maybe this is the reason why patient presented with retrocalcaneal pain. Okay, so retrocalcaneal bursitis and non-insertional tendinosis go together because they are both biomechanical because of the overuse of the Achilles tendon. Okay, so yeah, retrocalcaneal bursitis, non-insertional tendinosis of the Achilles tendon. I don't know, maybe there is Haglund deformity here, but not very convincing. Haglund deformity is normally a bony bump here. Always look for Haglund deformity when there is non-insertional tendinosis and retrocalcaneal bursitis. Always look for that bony bump. I have actually a case of Haglund deformity, maybe show it to you in the future. Yeah, so yeah, you did very well. That's a very good case presentation. All right, let's see what we have responses here. Insertional, Haglund triad, PDNS, okay. All right, okay. All right, okay, let's move on to the next case.
دكتور حسن جليل.
نعم
دكتور حسن تفضل حتى.
Okay, 5 minutes starting now.
Yes. X-ray of left hip and AB and oblique view of left hip and lower tibia show soft tissue swelling in upper thigh. No bone lesion, no fracture. You can see another modality of imaging, MRI. multi-sequence MRI, multi-planar, show well-defined fusiform heterogeneous hyper-intense lesion seen in anterior compartment of thigh. Other subcutaneous layer with the heterogeneous intensity and fusiform in shape. differential diagnosis ممكن الساركوما muscle sarcoma, a malignant nerve sheath tumor. ممكن ممكن نشوف صوت and paper appearance ممكن بارا جانجليوما try and finish 3 different.
You finished?
Yes.
Okay, so let's go back to the history: progressive soft tissue swelling, anterior left thigh, no medical history. Yeah, you did really well on the X-ray. You detected the soft tissue mass or swelling in the anterior aspect of the left thigh. One thing that probably you should have mentioned, what do you think you should have mentioned? Relevant negative.
joint involvement.
Lack of calcification.
Lack of calcification.
Why is it important on soft tissue masses and tumors we comment on soft tissue calcification?
بالنسبة للكالسيفيكيشن ممكن على الشكل الكالسيفيكيشن إذا dystrophic calcification ممكن يكون مايوسايتس اوسيفيكانس، ممكن tumoral calcinosis. التايبس اوف calcification نعطي hints إنه على التايب اوف تيومر ممكن narrow differential diagnosis of tumor or benign lesion. Yeah, you're right. I mean, myositis ossificans will have different type of calcification compared to dermatomyositis. But when it comes to soft tissue sarcoma, how is it useful to us that we know whether the tumor has amorphous calcification or not? I don't know. I don't know.
Okay, so when we looked at the MRI scan, you did really well. You said you described it, and you said soft tissue sarcoma. Calcification will help you if this patient had calcification on the radiograph. You could say, if there was calcification, you'd say this is most likely synovial sarcoma. okay, because synovial sarcomas tend to calcify on radiograph. But this one showed no calcification, so it could be any other different type of sarcoma. So my question to you here, which is really the most important thing, is what is the role of MRI scan in this patient?
MRI scan soft tissue sarcoma يعني detect the يعني precise يعني site and size of the lesion, show the soft يعني show يعني invasion يعني invasion يعني determine if there is any invasion to other layer or muscular compartment, if there is any nerve or يعني vessel encasement or invasion. يعني more anatomical details, show more anatomical details more than CT or X-ray in this type of lesion.
So what do we call all of this? What you just said, can you just summarize it in maybe 2 words?
يعني هي مو soft tissue characterization أو
It's actually not for soft tissue, not for tumor characterization. It's for local staging.
local staging, yes. يعني show extension, invasion, nerve muscular يعني nerve invasion or vascular invasion.
Yeah. I'm not sure if you actually commented on the relationship between the tumor and the neurovascular structures, because there's fat playing here.
Yes,
I think you said no intraosseous extension, but really the neurovascular structures are very important. The other thing is compartmental breach. I don't know if you commented on compartmental breach. You said the tumor is in the anterior compartment, and again in the thigh we don't really use the term anterior compartment. What compartment is this?
A lateral compartment.
There is no lateral compartment in the thigh. So there is hamstring compartment.
Yes.
Okay, this is hamstring. Sorry, quadriceps. This is quadriceps compartment. This is hamstring compartment, and this is adductor compartment. So there's no lateral compartment. And we don't really have the anterior, posterior, or medial. So we need to, again, get the terminology right. Quadriceps, hamstring. This is actually gluteus maximus muscle here because it's higher. The tumor is high in the thigh, proximal. So you have adductor, you have hamstring, and you have the quadriceps compartment. If you can localize it to one muscle, it would be even better. So in the quadriceps, you have 4 muscles. And I think this is most likely in the rectus femoris muscle, because we see vastus medialis, intermedius, and lateralis here. Most likely, actually, this is rectus femoris muscle. And describing the signal intensity is also important. So this is heterogeneous signal intensity on both T1 and T2FS with patchy mixed enhancement. The signal characteristics are very non-specific. There is some high signal intensity on T1, which may suggest hemorrhage, and that would indicate central necrosis, and that's why we have areas with no enhancement in the center of the tumor, which is the necrotic part of the tumor. So again, and you can also comment on perilesional edema, no intraosseous extension, no intra-articular extension. Sorry, I'm trying to get rid of this. No intraosseous, no intra-articular. Fat plane is preserved between the mass and the neurovascular structures. No compartmental breach. This tumor is localized within the quadriceps compartment. There is no compartmental breach. And compartmental breach is the single most important factor in local staging. It's more important than even relationship with the neurovascular structures. So that's the most important thing. And again, and we said when we take cases, we also make recommendation for further management. Recommendation for further management for this patient is a referral to sarcoma surgeon, and also for image-guided biopsy after consultation with a sarcoma surgeon. Okay, so that was that. Let's check responses.
العفو استاذ هارون، ايش قد بقوا كيسات؟ اكو هواي بعد؟ لا
أنا عندي تقريبا 21، بس إذا تريدون نتوقف بهاي النقطة
اي والله
بعدين
نتوقف
نكمل.
لانه يعني قسم من